discussing on this topic, antibiotic prescription with a renal impairment. So what I feel that patients with a renal failure are always at risk of toxicity of many drugs, not only antibiotics, many drugs. And because we should avoid drug toxicity in such group of the patient, most of the times it is iatrogenic and avoidable. Most important is avoidable. If we understand, we can avoid this drug toxicity. So whenever you are choosing any antibiotic with a renal impairment, three important considerations based on the two important parameters. What are the three important considerations? One is optimally treat an infection. Treatment should be optimum. Other important is always whenever you write any prescriptions, adverse effects should come in your mind. And third is to minimize the resistance. Antibiotic resistance is an important problem across the world, across India, particularly in our part where it is used without evidences with the controlled availability of the medicines. And the two important parameters which we should consider, one is the pharmacokinetic alteration, other is pharmacodynamic. So I think most of you might be remembering these two words, pharmacokinetic and pharmacodynamic, from your MBBS days. So what is pharmacokinetic? Just to recapitulate. Pharmacokinetic is go in, go through and go out of any medicines. In, through and out of any medicine is pharmacokinetic. That in medical term, you can see absorption, distribution, metabolism, and then elimination from the body. And CKD patients, particularly those who are on dialysis, there is additional burden. When you put this patient on dialysis, some of the important drugs, particularly the water-soluble antibiotics, are removed from the blood. So concentration will go down. And in between the dialysis period, because dialysis is not continuous, every third day your patient is going on the dialysis. So there will be little clearance. So there will be too much of the fluctuations. So all these things we should consider before prescribing antibiotics. What is pharmacodynamic? This is actually, the pharmacodynamic part is very important. That is to understand the how drugs behaves once it go into your body. So important consideration is protein binding. Why I am talking about the protein binding? Majority of the patients on dialysis or CKD patients or with a renal impairment patients has less protein, and the free drug availability would be relatively more. So chances of drug toxicity is more in that group of the patients. Volume of distribution, that is also important. When there is no normal urine output, so what will happen? The patient's volume of distribution, which you usually assume that would be the 60 to 70% of your body weight, might go up really. So that might be larger. Kidney clearance, that is another important. Your GFR is low, the excretion would not be normally that is given in the textbooks on the drug leaflets. So it might be different depending upon your GFR. And non-renal clearance. So the drug, when it is not eliminating through the kidney, from where it is eliminated from the body. Whether if kidney function is less, whether the liver is able to compensate that metabolisms, that is also important consideration. So we have to understand the pharmacokinetic and pharmacodynamic of any antibiotics or any drugs when you are writing these drugs for a patients who have renal impairment. So we all must be knowing about this curve. What is this called? Concentration time curve of a drug. Particularly, it is very important for the considering antibiotics. So what we can see here, once you take the drugs absorb and peak level go up. So here at the peak, it is called Cmax. concentration maximum, and then gradually it is eliminated from the body, it go down, and there is particular MIC. MIC means minimum inhibitory concentration of the drug. At that level, at least it inhibits the growth of the bug. So that level always you should keep in the mind, and at that level the drug should be maintained if the patient is really having some bacterial infection or some infection. So Cmax, minimum inhibitory concentration, and area under the curve, that is important. So some of the drugs, why I am talking about this, I will just, you will know in the next slide. There are two important pharmacodynamic properties of the drug or any antibiotic. One is time dependent killers, other is the concentration dependent killers. So in one kind of the drug, time is very important. Other, the level is very important. So how? Which drugs? Let us see. Concentration dependent. One of the important drugs when we talk about the drug toxicity causing renal failure, everyone might be remembering from your MBBS days, that is amino glycosides, amikacin. And other very important drugs which are commonly used are ciprofloxacin, levofloxacin, quinolone groups of the drugs. These are the concentration dependent drugs where what is important is the Cmax of the drugs. Concentration maximum is very important. AUC is very important. Where they work, they have sidal effects on the bacteria. Other is the time dependent drugs. In this group, drugs which comes very important drugs like penicillin, cephalosporin, carbapenems, vancomycin, linezolids, macrolides, commonly used drugs. Most of these drugs are have time dependent kinetics. So here in concentration dependent kinetics, area under curve is important. Here in time dependent kinetics, time is important, where you have to keep the drug above the MIC for longer period of the time. Just also remember this figure. We have only 6 class of antibiotics working in the 6 different ways. 6 different mechanisms of action of these antibiotics are. I am just starting. DNA synthesis inhibitor, quinolones. Protein synthesis, linezolids. Protein synthesis inhibitors, amino glycosides. Folate synthesis inhibitors, cotrimazole. Cell membrane dysfunction is daptomycin, and cell wall synthesis inhibitors, maximum drugs act through that we use day to day. Particularly, it is used very commonly in tertiary care institutions like us, are beta-lactam and vancomycins. So these are all the only 6 class of the antibiotics. They act through different ways, and some of the drugs are concentration dependent. So what are the concentration dependent? Here we can see lipoglycopeptides, lipopeptides like daptomycins, fluoroquinolones, and amino glycosides. They are concentration dependent. 2 important class of the drugs, beta-lactam and vancomycin, and linezolids are time dependent kinetics. So let us see 2 important adjustment, particularly in the patient of the renal failure. One is the concentration dependent antibiotics. Here the dose would be normal like any normal individual, but prolong the dosing interval. That is the most ideal. In time dependent kinetics, you should decrease the dose and keep the dosing frequency constant. So that is the principle of ideally using this kind of the drugs. So now I will go one by one. So because I think in day-to-day life or in day-to-day practice, it is very important to know all these commonly used antibiotics and how we should use this in real-time practice. So beta-lactams, almost all of you might be remembering this. This group of the drugs are penicillin, cephalosporin, and carbapenem antibiotics. Most frequently used medicine in the tertiary care institution, work by bacterial cell wall synthesis inhibition. Beta-lactam exhibit time-dependent pharmacokinetics. It is time-dependent. So, what would be your choice? Decrease the dose and maintain the dosing interval so that most of the times drugs level in the body would be above your MIC value. So that is the principle. Or particularly in the patient with a renal impairment, particularly chronic renal disease patients, has extended half-life of this beta-lactams. So that prolong the length of the time and that concentration will remain above the MIC value. So the preferred regimes would be use the loading dose, whatever is given for the normal person, and then either use intermittently, frequently, or you can use some of the drugs in continuous infusion so that most of the times during the day times it will remain above the MIC value. So the drug would have the full effect on the bug. Important thing to remember with all these drugs are the CNS disturbances. That is the most common adverse effect of this drug. Confusion, myoclonus, and seizure can occur. This happens mainly because of the diminished clearance from the kidney. And this beta-lactam rings levels go up. Other important things are usually seen in patients of the chronic kidney disease are decreased protein binding of the beta-lactams. And so free beta-lactams would be high, and that would be in the CNS, causing disturbances. And uremia per se have a lot of other problems. Already patient at the risk of uremic encephalopathy might predispose, reduce the threshold of these side effects. Other important groups of the beta-lactam groups comes in the penicillin. One of the important controversy always comes in the mind, particularly if some of us from nephrology can understand. Sometimes what happens, only you have the reduced GFR. Once this filtration here at the glomerular bed, you have the filtration. So filtration happens and some of the drugs here is secreted again. So some of the disease only glomerulus is predominantly involved and secretion is intact. So in that group of, you need full dose, but in some of the disease, glomerulus as well as the secretory tubular activity also go off. So you might have the confusion where there is the dose adjustment, but unfortunately, or you can say this in the simplified way, most of the drugs are not taken the consideration of the tubular secretion. Most of the leaflet will show you that is based on the creatinine clearance, that is based on your GFR of the drugs. So we should not be that much confused regarding whenever you are doing any clinical activities. So coming to other important drugs like cephalosporin, we have at present 5 different generations of the cephalosporin in our hand. So as you go from first generations to 5th generation, first and second generation predominantly cover the gram-positive organism. Third and 4th generation is covering your gram-negative organisms, and 5th generation again came back with gram-positive cover. There is only one drug, ceftaroline. Ceftaroline is the one drug, 5th generation, probably not available in India, likely to be available. So that is the predominantly towards the gram-positive. Why I am talking about this today? You can think of when any patients comes to you and the patient has severe sepsis or bacteremia is there, you have to choose the antibiotics. Which antibiotic you will choose? Beta-lactam, gram-positive cover is there, staph infection is there, or vancomycin. So if that bug is sensitive to cephalosporin, we should always try to use this cephalosporin group of the drugs because they have the quicker actions. It is possible that over the times you might have the 100% efficacy of the vancomycin, but very quicker actions. if the patient is septicemic, you require very quick actions, you should use beta-lactam antibiotics. Cefazolin or even amoxicillin and clavulanic acid combination is a reasonable choice. It may be administered 3 times or 4 times more frequently. Even in dialysis patient, you can use more frequently. So at least there would be concentration above the MIC for longer period of the time. So gram-negative organisms and cephalosporin. One important example is the ceftazidime. Most of you might have done duty in the COVID periods and might have used Jevicepta. So that contains ceftazidime. Ceftazidime is 3rd generation cephalosporin, and it is one of the very good options for the gram-negative organisms. And one study, a very large study, have shown if your MIC value of the ceftazidime is more than 45% of the dosing interval, they have more benefit, particularly in treating the hospital-acquired pneumonia. So why I am telling it time and again, it is better to keep these drug levels most of the times in a day above a MIC value to get the full time-dependent kinetic benefit. Other important drugs is carbapenem. Activity against beta-lactamase producing gram-negative organisms. Everyone might have heard the name of the imipenem, meropenem. These are doripenem, ertapenem. These are the drugs which comes under this category. Imipenem was the first drug of this class, and major side effects, particularly what we observe in our day-to-day practice, is the seizure, and should be used with cautions, particularly if there is CNS lesion, neurologic disorders, and particularly the kidney disease is there. The levels go up, reduce the threshold of the seizures, and predispose the patients for the seizure activity. So that is important, and we should know about, because these are the commonly used drugs. In one of the largest review, adverse effect which has been noted in more than 3,000 of the patients, overall seizure report was 2%. Just see, if you are using at the GFR of the 20 ml per minute, the incidence of the seizure goes up to 11.8%, 12%. And if you are using more than 3 grams per day, which is the usual dose, with the renal impairment, the seizure activities, incidence, adverse effects go up to the tune of 16%. So always think of, whenever using this antibiotics in patients with a renal impairment, whether next day in the round your patient is looking more confused. So really this is the worsening sepsis, or it is the worsening effect of the high dose of this drug, because we all use these drugs day night, everywhere, in every ICU it is used. So that becomes very important. And other important things happens simultaneously. Many patients with the seizure activities, if the patient is on valproline, the level of valproline reduced by 80%. And sometimes this low level of this valproline, which is anti-seizure drug, again predispose the patient for seizure activity. Other important drug is vancomycin. Whenever vancomycin comes in the mind, one renal toxicity also comes in the mind. Probably vancomycin is nephrotoxic medications, but it is usually thought to be very safe if you use very cautiously. And there are few things which I will tell you. It is one of the drugs which are commonly used for gram-positive organisms, particularly gram-positive organism. When we talk about the most dangerous organism is Staph aureus, and 2 important kind of MSSA or MRSA, you all might be aware about this, if this is methicillin sensitive or this is methicillin resistant. Never use this drug in methicillin sensitive Staph aureus. It is not required. The better drug for that is 1st generation cephalosporin, or you can use even amoxicillin with the clavulanic acid. Or for MRSA, the drug of choice is vancomycin. Definitely, this is the first line agent. Important thing to remember with the vancomycin, it is excreted through kidney, 90% unchanged form. And so AUC or MIC ratio is the pharmacodynamic parameter linked to vancomycin effectiveness. Other important drug, it is very convenient for us to use in dialysis patient. Once you give this drug, you can forget giving it for 7 or 10 days. If GFR is less than 10, you can give single dose. You can forget about the 7 or 10 days, and then you can repeat after 7 or 10 days. But that is with the conventional dialysis. But high flux dialysis, that is also becomes important if your patient is getting the CRRT, where the pore is larger. If your patient is getting the high flux dialysis, where the clearance of the drug is possible, then you have to adjust the drugs accordingly. So that we should keep in the mind. And nephrotoxicity of the vancomycin alone is not that high, but it increases 7 times if vancomycin is used with amino glycosides like amikacin. This increased tremendously. And recently many reports have come when you are using vancomycin, you should take precautions if you are using the piperacillin tazobactam also. Then the nephrotoxicity of these drugs go up. Baptomycin, probably you might not have, many of you might not have used. This is primarily used in ICU patients. It is used for bloodstream infections associated with the catheter, whenever you have any necklines, and when you have the prolonged catheter associated urinary tract infections, sepsis, then it is the drug which is used. It acts by inhibiting cell membrane formation of the bacteria. It has also the concentration dependent bactericidal activity, and it is again very important drug. Highly protein bound with a low volume of distribution, making it an ideal agent for treatment of the bloodstream infections. But it should not be other important information of what I want to give you. It should not be used in patients with this pulmonary infection, pneumonia, because it has interaction with the surfactant. It is primarily 78% extracted in the urine as unchanged form. T-half of this daptomycin is prolonged 30 hours in patient with receiving hemodialysis compared to 8 hours in patient with a normal kidney function. But again, we have to remember the serious side effect of this medicine is the myopathy, eosinophilic pneumonia, and peripheral neuropathy. You go on giving these drugs, the patients will land up with the problem. So whenever next day in the round you go, you must keep in the mind whether our patient is developing some serious side effects of these drugs. And many of the patients on the sepsis has INR problems. Prolonged INR, prolonged PTA, PTT is there. So if this patient is on the drug, it may say probably you have the false prolongation of your PT and INR. So that we should also keep in mind. Other drug is the linezolid that is available. Tedizolid is not available in India right now, but again it is a bacteriostatic drugs used mainly for the gram-positive organisms, used in place of the vancomycin. Better part from the renal point of view, they do not require dose adjustment for the kidney function, but bad part is the two metabolites, particularly inactive metabolites. It is thought that accumulates in the patient with the renal failure, and it is thought that some of the side effects like the myelosuppression and some of this optic and peripheral neuropathy might be happening because of this accumulation of these inactive metabolites in renal failure patients. But as such, thrombocytopenia is very common. That is the effect of this myelosuppression. So that we should always keep in the mind, but it is convenient to use in the patient with the renal function, with this normal renal function, and with the renal impairment without dose modification. But side effects should always keep in mind. That is important, and it is available orally, in oral form. Vancomycin oral formulation is available, but is used for the different purpose, not for the daily usage. So amino glycosides is another drug that I want to take it separately. So variable frequency or variable dose. I am just giving you example of the gentamicin, 2 milligram per kilogram body weight of the loading dose, followed by 1 milligram per kilogram. One just assumption is there. If your serum creatinine is 2, so multiply it by 8. That will come as a 16. So repeat the next dose at 16 hours. And when you want to go for the variable dose frequency, give the loading dose. Loading dose remains the same for all antibiotics. So 1 milligram per kilogram maintenance dose, total dose divided by serum creatinine every 8 hours. More frequently you can give. But remember, this is the concentration dependent. Kinetics is there. So we want to keep the level high. So what is important here? What we can see here with amino glycoside. Once you give, it is water soluble also. So it clears very rapidly after dialysis. So always should be given after dialysis, not before dialysis or not during dialysis. So after giving IV, its peak level go up, then slightly go down. Here you can see the post-antibiotic effects. This post-antibiotic effect, what happens? Its inhibitory concentration little bit continued. And there is one effect called the post-antibiotic leukocyte enhancement effect. So that is important in consideration of using this aminoglycosides. So what is important for keeping this above the minimum inhibitory concentration, but major effect is the sidal effects of this drug on the bacteria that comes with the concentration peak. Let it go peak. And what is the advantage of this picking up and this dose interval? Just I am telling you. So what happens? It is a toxic drug. Nephrotoxicity is there. It is taken into the tubules, cause tubular injury, and also ototoxicity. And vestibular toxicity is very high with all aminoglycosides. So important is there, take the advantage of the high concentration giving the loading dose and increase the interval. Let it come down. Take the advantage of the post-antibiotic effects. So in amikacin, it has a different ball games. So this is the reason why we use it intermittent dosing, interval dosing, not a continuous requirement is there, because side effect of these medicines becomes very high, particularly this kidney injury and ototoxicity and vestibular toxicity. So dose adjustment is very important. Just for the example, dose of aminoglycosides, 5 milligram per kilogram on average, actual concentration at 9 hours on day 3 is 5.4 milligram per liter, and target what we want to keep it is 2.7 milligram per liter. So when we should give the next dose, that is always comes in the mind. So target divided by actual into the dose of aminoglycosides. So 2.7 divided by 5.4, it will be 2. So into 2 into 5, so 2.5 milligram per kilogram body weight, that would be the next dose. So thus you can have you can remember something, how to go quickly calculating this dose and use in day-to-day practice. Fluorocanolis is another important drug. Most of you might be knowing that it acts through the DNA synthesis inhibition. It has some antiviral properties also. So many of the persons have used these drugs for the antiviral properties also. And it has the concentration dependent pharmacokinetics that I have already discussed about. So except for the moxifloxacin, fluorocanolis are cleared by the kidney and will need dose adjustment in patients with the impaired kidney function. Side effects, particularly it should be avoided in children, tendon rupture, peripheral neuropathy, CNS effects. These are common side effects. Sometimes it chelates some of these di or trivalent cations. Particularly it is important for the patients on dialysis who are getting many of the calcium based phosphate binders. So that we should always keep in the mind. And so you might have the potential treatment failure if you are treating CKD, MBD patients, and if you are using for longer period of the time of these quinolones. In addition, caution is warranted when combining fluorocanolis with the long QT interval of the drugs, which are causing, particularly one very common drug is antiemetics. That prolongs QT interval, and many times we used both in the combinations, antiarrhythmic drugs. So antimicrobials with the CKD, common required renal dose adjustment. Most of the drugs requires adjustment except ceftriaxone, moxifloxacin, macrolides, doxycycline, clindamycin, and linezolid. These are the safer drugs. You have not to think of too much. Careful monitoring, vancomycin and amikacins. Trimethoprim and sulfamethoxazole are not a real sense antibiotic. It are the chemical agents which are used as antibiotics. So data about the metabolism is not too much available as available with the other drugs, other antibiotics, but it is thought to be safer, and particularly the trimethoprim, the drug alone is bacteriostatic. Sulfamethoxazole, sulfonamides group of the medicines are usually bacteriostatic. So usually trimethoxazole, which contains sulfamethoxazole and trimethoprim, and concentration of the sulfamethoxazole should be 20 times higher than the trimethoprim. So this is the reason why 100 and 400 combination comes. If trimethoprim is 100, sulfamethoxazole should be 400. So that combination that should be maintained. So just antibiotics safe in renal functions. Mnemonics is there, that the dancer. Just you can remember doxycycline, ampicillin, napsilin, ceftriaxone and cifoperazone, erythromycin and rifampicin. These are the safer drugs. And you also remember that serum creatine and GFR, whenever your GFR go down, serum creatine levels go up. That we should always keep in the mind, and you should think of always calculating the GFR. GFR for formulae. Most of the drug leaflets has already formula written. Everything is there with how much GFR, how much the drug needs to be given. That is already given there. Most of these drug leaflets use this Cockcroft Gold formula, but you can think of using some other formula also. There is not too much of the variation, particularly the drug level for the drug level requirement. So just Dr. Himanshu has already taken the class on urinary tract infection, so I'm not going to talk too much about that. But choosing the drug for the urinary tract infections, you should always think of the which drug would have the better concentration in the urinary tract. So amongst these all groups here, what we can think of, the quinolones, ciprofloxacin, levofloxacin achieve good urine concentration, and majority of us try to prefer this kind of the drugs for the shorter urinary tract treatments. So definitely I am not going to talk in details. So drugs most likely to be dialyzed are low molecular weight, less than 500 daltons. On hemodiafiltration is another mode of dialysis. I am not going to talk a little bit because the pore size of the dialyzer is very large. So there even less than 20,000 daltons can be removed. So low protein binding is less. So free drugs would be more. So that drug is likely to be dialyzed. A small volume of distribution. If the drug is water soluble, definitely this is going to be dialyzed. Like the amino glycoside is 100% dialyzable. Vancomycin is not at all dialyzable because of this property. So removal by CRRT, again, we should always think of volume of the distribution, molecular weight, protein binding, route of excretion. CRRT I am talking about because the dialyzer used in that category of the modality of the dialysis is a little bit different, having the large pore size of the dialyzer. So what kind of the dialysis your patient is going on, particularly it is used in ICU patients, particularly Dr. Banani, and we are also using whenever we are the sick patient. So you can just think of why I'm talking about, give a little bit of hint about this CRRT versus intermittent hemodialysis. what we can see here, the blood flow or dialysate flow. Blood flow is very slow in CRRT. Usually this is a smooth dialysis. Dialysate flow is very high in intermittent dialysis. It is very low in continuous renal replacement therapy. So that kind of the differences are there. That is not for your use. That is, leave it for the nephrologist. But I'm just giving you example. So how to choose and give the antibiotics, looking at your GFR value. A man, 75 years man, 80 kilograms, serum creatinine of 3.8. Calculate your GFR. It comes under the category of the moderate renal failure. GFR is falling between 10 to 20. And so moderate renal failure, you have to give ciprofloxacin, half the normal dose. See, whenever you have confusion, try to see the drug leaflets. It is already written there, and that should come in your habit. And now you have the Google Baba, so you can always think of going on to the Google, see this how does people do. Yes, Sanford. I'm just coming on that. So serum creatinine and GFR. Sometimes the serum creatinine value is misleading. Your GFR really might be very low, particularly the elderly patients. If the patient has muscular dystrophy, anorexia, malignancy, just I am giving you why this is there. Because creatinine is synthesized from the muscle metabolism. So everything is related to the muscle. If the muscle mass is less, serum creatinine value is likely to be less, irrespective of your GFR value. So that we should also keep in mind. So ideal drug
for a renal patient
is non-renal excretion.
Not renal excreted, has no side effects.
No side effects.
It's an active drug.
Probably this is in my inbuilt. Yeah. So take care with the following drugs: low therapeutic window, renally excreted amino glycoside or digoxin, active metabolites which are renally excreted, particularly the morphine-like of the drugs. Remember to increase the dose whenever our patient is improving from the AKI, acute kidney injury. We forget to increase the dose if your patient is already in the sepsis. So modify your prescription on daily basis. Where to work for information? That Dr. Banani was telling, a lot of information are available on literatures. So renal drug handbooks, drug prescribing in renal failure, dosing guidelines for the adults, drug companies, many clinical papers you have to think of whenever you are trying to think, trying to adjust this dose of the antibiotics. So that's all from my side. If any one of you have any questions,